Hey everyone, we are going to go through the respiratory system. It's not a very long presentation, thankfully, so there aren't multiple parts, just this one. Taking a look at the system, just an overview of what we need to make this thing actually work. We need ventilation. This is the movement of air in and out of the lungs. So every time you take a breath, that's an example of ventilating. Then we need diffusion. So that air comes in while we ventilate, but what we really need to do is exchange oxygen for carbon dioxide in the alveoli, which you can see. Oh, there's my arrow. Here are your alveoli and the capillary membranes where that happens. But that doesn't do us any good if we don't have any circulation. So this is actually a function of the cardiovascular system to get the blood in and the blood out. So those are the three main things that need to be able to work in order for us to effectively breathe. And doing a little bit of anatomy here, we've got the upper airway. And we have the lower airway. So when we talk about upper respiratory infections and lower respiratory infections, this is the areas that we're talking about. You have your diaphragm. You have your chest wall and thoracic cage. Your mediastinum, which is the area here right between the lungs. And we have these 3 lobes in our right lung and 2 lobes on the left. And this picture actually does a really bad job of depicting reality, where the bronchus that goes into, my mouse doesn't want to work, the bronchus that goes into the right lung is actually, these look like they're at the exact same level, and they're not. The one on the right is a little bit higher. So a lot of times when we intubate people, we really want to listen to lung sounds, and we always listen to lung sounds on the left first, because if we don't hear anything, then we'll listen to what's on the right, and we might hear something then on the right. And oftentimes, if we go in too far, we end up just intubating the right lung. So you got to pull back, and you want to have the ET tube, the endotracheal tube, just up here, so you don't just intubate one lung. So sometimes you'll hear about right stem intubation, and that's what that's about. And then, like I said, you got your 2 lobes on the left. So here we have our pleural cavity. This is the lining of the lung. You've got, if you can kind of picture like one of those long, skinny clown balloons where they make like dogs and stuff like that. Skinny little tube that wraps around here. And the inside of this tube that touches the lung, that's called the visceral pleura. And the side that touches the rib cage, that's called the parietal pleura. And it's filled with fluid, so it's got this nice movement as we breathe, much like the heart does in its pericardial sac. The pressure in here is actually negative, so it's -4 to -10, and this is what helps us just naturally breathe. Now let's talk a little bit more in detail about that gas exchange. We have air that comes in through the bronchi into the bronchioles, which are the smaller guys, then into the alveolar ducts. Where's my arrow? Down here into the alveoli, and then we have it surrounded by all of these capillaries. Inside the alveoli, we have what's called surfactant. And the term surfactant actually is generated from the concept of a surface active agent. So if you can remember that, it covers the surface of the alveoli. It's active in that it keeps it nice and slippery, like soap. Soap is actually a surfactant. And in decreasing that surface tension, we have it nice and flexible and compliant, so it can easily expand and contract with the lungs. And just a fun fact that's timely, This is what actually, the surfactant is what's being destroyed. This is what they've come up with so far. I suppose it could change. But to what we know now, COVID-19 actually destroys this surfactant. And so we end up with these really stiff, compliant lung alveoli, which end up not being able to exchange any gas. And it's irrecoverable. All right, so when we talk about moving the blood in and out, the right ventricle, all of what is squeezed out of the right ventricle, all of the output from the right ventricle goes directly into the pulmonary system, nowhere else. And what's interesting, though, is as the right ventricle and the left ventricle, right, we have a heartbeat and they squeeze at the same time. Even though they do, the right ventricle only has a pressure of about 18 in the pulmonary artery, where the aorta is 90. So it's just really interesting. It's a very low pressure system, pulmonary system is. So the gas exchange occurs at what is called the alveolo-capillary membrane. There's also a significant complex lymphatic system within our lungs. So we do have all that cilia in our nostrils, all those nose hairs. We have our cough reflex. We have these other things in place to try and keep junk out of our lungs. But those systems can fail. They don't always happen. They don't work perfectly. So when we get stuff down in our lower airway, we've got the lymphatic system to eat it up and move it out. All right, more specifically on ventilation. Often the term ventilation and respiration are used interchangeably, but they are not the same word. So respiration is actually the gas exchange that goes on. It's perfusion. Respiration is perfusion. It's the swapping of the O2 and the CO2. Ventilation is only the process by which we put air in the lungs. Just because you ventilate a person, you put that air in, there's no guarantee that the perfusion is going to happen. So ventilation is just moving air into the lungs. The thing that gets people confused is the ventilatory rate is the same thing as the respiratory rate. So even though we call, somebody respiratory rate, they've got a respiratory rate of 18. Well, that means they're ventilating 18 times. They're sucking air into their lungs 18 times. It does not mean that they're actually perfusing. It just means that they're ventilating. And then we have something called the minute volume or minute ventilation, and it's basically the amount of air that we move over a period of 1 minute in and out of our lungs. The amount of air that we move into our lungs on one respiration, so breathing in just one time, that amount of air is called tidal volume. And you will see if you look at a ventilator, you look on the screen, all of the different numbers that are on there, all of the different settings, you'll see something that says tidal volume. And quite often it's like 400 to 600 milliliters, and with 450 to 500 kind of being the general setting for most adults. But that tidal volume is just that one breath. So it's the amount of air that every time that they put a breath into a patient, that's the tidal volume. But you can see in this picture, let's see, it's the next thing. Yeah, dead space. So you can see in this picture, on the right, you have your little alveoli exchanging gas. You've got nice pulmonary blood flow. It talks about the minute ventilation and alveolar ventilation, and everything's happening nice and beautiful on the right. But on the left side, really nothing's going on. And the fact of the matter is we have all of these alveoli, like, I don't even know, hundreds of thousands in there, a ton. I know it says in your book, but I forgot what it said. But they're a ton, and they're not all used. So you may notice that sometimes if you do some really crazy extensive exercise later, afterwards, you'll be kind of coughing a lot. And what happens is you recruited a whole bunch of alveoli that you haven't used in a while, and it's a little bit irritating. But we do have a significant portion of our lungs that we don't even use because we don't necessarily needed as we sit here and do nothing, but listen to a boring presentation. So anyway, that space in our lungs that we're really not using and there's no perfusion going on, that's called dead space. So something to know, because it's in red. Diseases that limit our respiratory rate, so we're not taking very many breaths per minute, or that decrease our tidal volume, where we're doing really shallow respirations, these result in decreased perfusion, as would make sense, right? And when we have a decreased perfusion, we're not blowing out our CO2. So in the box, you'll see I have hyperventilation will result in hypocapnia. So hyperventilation, breathing super fast, just blowing off that CO2, ends up with low CO2 in our arterial system. Having a low CO2 in our arterial system is called hypocapnia. And that low CO2, the PA stands for the pressure in the arterial system of CO2, and it's measured in milligrams of mercury. And it should be 35 to 45, just as an FYI. And we have hypoventilation, which is just very shallow breaths. We're not getting a lot of air in. That's going to result in hypercapnia, which means we're going to have too much CO2. We have a ton of retained CO2 because we're not blowing it off. So the best way to know if our ventilation is actually effective is we do an ABG. So we draw some arterial blood and we measure the gases, the O2 and the CO2 in there, to see if there's actually perfusion going on. And that lets us know if we're breathing in enough air to perfuse. So the mechanics of getting the air in and getting the air out. We've got a number of muscles that are used for this purpose. Down at the bottom with the blue square, you can see your intercostal muscles and your diaphragm. Those are the major muscles. And then we have accessory muscles at the top in the red box. And what happens is the accessory muscles don't kick in until things get pretty bad. If we're having a really hard time breathing, you'll see people using their accessory muscles to help them breathe. The elastic properties of the lungs and the chest wall really help to give us this elastic recoil. It's an autonomic function that happens without us thinking about it, though we do have control and we can breathe as fast or slow as we want purposefully, but we naturally do this, and that's based on the process of elastic recoil. Also, like I had stated, the surfactant, decreasing the surface tension in the walls of the alveoli, really helps to make this process work smoothly. Diseases that disrupt these two natural processes, again, will require the use of our accessory muscles. And this is, when people do this, what you'll see is called retractions. So if you say somebody's like, oh, this person's having a hard time breathing, and they're retracting, that's a really late point of the game, like tripoding. Like, this person's really, really having a hard time perfusing and ventilating. So that's called retractions when we use accessory muscles. The resistance to airflow can cause problems if we're having a really hard time getting air in. The major resistance occurs in our nasal cavity, our pharynx, and our larynx. There really shouldn't be any resistance at all, for the most part, in our lower airways. We have all that slippery surfactant, everything's nice and elastic. If you do have resistance in the lower airway, it's from a disease or disorder type of process. Other things that can go on actually in the upper airway that aren't natural, and they are a function of some type of disease or disorder, would be like anaphylactic shock, which we've talked about in the past, where the airway swelling. Sometimes you'll get people that have had a tonsillectomy and they have a lot of swelling and bleeding going on back there, or you have trauma, something that's blocking the upper airway and causing resistance too. Those are things that could be abnormal in the upper airway. But you should never have really any resistance, like I said, in the lower airway. So let's talk a little bit about signs and symptoms. Just to clarify, signs are things that you see as the clinician. There are findings on your physical exam that you see. Symptoms are things that you take when you're doing a history, whether it's a history of the present illness, a current chief complaint, or, a long family history, anything like that. These are things that are subjective to the patient. So patients can come in and say, oh my gosh, I'm starving for air. I'm so short of breath. This is called dyspnea. But the patient's complaining of it, and they could be having a panic attack. So they're really not having a breathing problem per se. It could just be on exertion. It could be lying flat. It could be our paroxysmal nocturnal dyspnea that we've talked about during the cardiac lecture, where you wake up suddenly. People with cardiac issues wake up suddenly in the middle of the night, short of breath. These are complaints that the patient has, and those are symptoms. But something like retractions, like we just talked about, this would be a sign, and you would document it as a sign because it's something that you're observing. And people may or may not have these signs when they're complaining of shortness of breath. The cough reflex, as I had mentioned, when we get irritants, we have receptors that sense these irritants in the airway, and it stimulates us to reflexively cough. In an acute situation, this is usually due to infection, right? COVID-19. I'm just going to keep bringing that up. I mean, it is a respiratory presentation after all. So you just have an acute, it came on pretty suddenly. It's going to resolve on its own, hopefully, at some point. And again, that's usually due to an infection. People can have a chronic cough, and it's usually the smokers having chronic bronchitis, or our patients with asthma. And we can have abnormal sputum, which is, I think, the most disgusting thing I encounter at work. I absolutely hate lung cheese, but we'll have abnormal sputum. It could be yellow, it could be green, and it can be bloody. And this is called hemoptysis. So it's bloody, frothy secretions. You see this often with people that have pulmonary edema. So when they have heart failure and things are backing up into their lungs, they're coughing out blood that's backed up from their heart. And then we have cyanosis. So this is a blue discoloration because we have, our hemoglobin is very inefficiently utilizing the oxygen or not getting enough oxygen, but it's not binding enough oxygen to give it that nice dark heme related color. So we turn blue. And then clubbing. No, not that kind of clubbing. I get really bored, you guys, when I do this. It's the bulbous enlargement of the fingertips, and this is from chronic hypoxemia. So people with chronic pulmonary conditions, you'll see this. They've got, the tips of their fingers are like big balls. Conditions or diseases or injury can cause things like hypercapnia. So this is our elevated CO2, which we've mentioned a couple times already, and it is the result of hypoventilation. I put up what's shown in a blood gas, and so you can see sometimes it's kind of a new thing to do a venous blood gas. So you'll see at some hospitals that they do VBGs instead of ABGs. And the numbers are different, obviously, right? Our arterial system should have a ton of oxygen in it, and our venous system should not have as much because we utilized it and we're going back to the lungs to get some more. So these are your normal ABG numbers. Hypoxemia. So this is when we have a low level of oxygen in our blood. So our whole circulation has a low level of oxygen. It is completely different than the word hypoxia. So some people, you'll hear them use the terms hypoxia and hypoxemia synonymously, and they're not. Hypoxia is just what happens when you have a localized area within tissue somewhere, because let's say you have an MI, so it's your cardiac tissue, or pulmonary embolism. Well, pulmonary embolism can end up with hypoxemia because it's in your lungs, so scratch that. But we have areas of hypoxia because there's a blockage of some sort, some type of difficulty where the tissue right there is becoming hypoxic. But hypoxemia is our blood. So it's not tissue, it's the blood that's got no oxygen or very little oxygen in it. Acute respiratory failure, it's defined as having PaO2 of 60 or less and or a CO2 of greater than 50. And usually you have both. It's kind of weird to have one or the other, unless you just intubated somebody. So sometimes, they intubate somebody, they're just blowing 100% FiO2, which is 100% oxygen, into the patient, and then you do their first arterial blood gas after intubation, and their CO2 will be a little bit high because they weren't breathing, presumably, and that's why they were intubated. But then you have your PO2, and it's like 160. It's something crazy because you've just blown tons of oxygen into the patient. But generally, if somebody's not breathing, they're not going to have much oxygen in them, and they're going to have too much CO2. Also, we can have issues with physical abnormalities or trauma to the chest, and this just disrupts the movement. People will fracture their ribs, and so they're not breathing very well, and so this can affect their ventilation. And then that pleural cavity that we talked about, you can have something called a pneumothorax, and this is where we get air or gas into that pleural space, and you end up with a collapsed lung. So it could be a puncture wound, a stab wound, a gunshot wound. Of course, I'm a trauma nurse, and those are the only things I think of. But it actually could just be idiopathic. It's not common, but when we have idiopathic spontaneous pneumothoraces or collapsed lungs, it's usually in young, tall, skinny males. But there is a genetic component to it. For the most part, this picture, it looks like they got a little slug in there. The lung doesn't collapse ridiculously to that small little slug, unless you did get this huge stab wound in your chest. But for the most part, you'll end up with a pneumo, and it's just, a little bleb up here that collapsed, not the whole darn thing. And then we have pleural effusions. So it's not air, but it's the presence of fluid. You can have, there's different types of fluid. It can be transudative, which is like clear. It could be exudative. It can be an empyema, which is really disgusting. It's a bunch of pus in there, and it's actually pretty common with older people that get pneumonia, and we'll drain it off. It's gross. Anyway, you can also have blood in there, and chyle, which is like lymphatic drainage. Now let's talk about restrictive lung diseases. So this is when the tissue of the lung is really stiff. It's not being flexible and elastic. You'll see a patient that comes in, if they have a restrictive lung disease, they'll have an increased respiratory rate, a decreased tidal volume, and a VQ mismatch. What the heck is a VQ mismatch, right? I didn't even talk about that. I considered putting it on the ventilation slide, but it's really kind of complicated, and you don't need to know the details of it, but I will tell you what it is. The V stands for ventilation, the Q stands for perfusion. I have no idea why it's not a VP mismatch, but somebody decided to call it a Q. So it's our ventilation to perfusion ratio. And like I stated, ventilation is just putting a bunch of air into the lungs. You can ventilate somebody, but that doesn't necessarily mean they're going to perfuse. So you can have somebody that you can fill their tidal volume is perfect, say it's 500, but they're just not perfusing. So you'll have what's called a VQ mismatch. So these are all of our restrictive, or actually just the most common restrictive lung diseases that you'll see in the acute care setting. So the first one, aspiration, this is when you get fluid or solid particles into the lungs. It's a super common, most common reason for pneumonia, especially in older patients, because maybe they've had a stroke, their muscle tissues are more lax, they don't have quick reflexes, so they end up aspirating what they're drinking. And that's why you'll see older people on thickened fluids, because we're concerned about them aspirating and ending up with a pneumonia. And it most often occurs in the right lung. Why? Because, like I had stated, the bronchus that goes into the right lung is actually a little bit higher up than the left. So it's the first tube it's going to hit and go down. So it's really common to have a right lung pneumonia when it's an aspiration pneumonia. And then we have atelectasis. So this is our collapsed lung. And it could be for multiple reasons that the alveoli collapse and shut down. It could be compression from like a tumor, something else that's going on, trauma. It could be obstructive, where the bronchus is obstructed for some reason, like a pulmonary embolism. Or it can be dysfunction of that surfactant lining the alveoli. It is a super common post-operative complication, and this is why it's super important when we have that incentive spirometry. It's that tube, the cylinder anyway, with the tube that comes out, where you tell the patient, a lot of people tell the patient to blow into it. It's not, you breathe in, you inspire, incentive. So think about incentive, the word incentive as inspire. So it's you breathe in as much as you can, and it has a little gauge on it, a scale on it, so you can see how much the patient's actually breathing in. And you want to get them to increase it before they go home, because they're going to end up with areas of atelectasis, and that makes them more prone to developing a pneumonia. Bronchiectasis is a persistent dilation of the bronchi. So we end up with that persistent dilation. It leads to inflammation, obstruction, and then it becomes fibrotic and stiff. This usually occurs in conjunction with other types of respiratory and systemic, like autoimmune issues. It does produce often anyway, not always, but foul-smelling sputum and hemoptysis, and clubbing's often seen with these chronic conditions. Bronchiolitis is the inflammation of the smaller, the lower airways, the bronchioles. It's more common in children, not that it can't be seen in adults, but it is more common in kids and even babies. It can lead to something called bronchiolitis obliterans, and this is where you have permanent scarring in the lungs due to the inflammation. Pulmonary fibrosis is an excessive amount of fibrous connective tissue in the lungs. It can be of unknown origin, which is idiopathic, or it can be secondary to a pulmonary or autoimmune disease. And this, the lung becomes really stiff and very difficult to ventilate. We also have inhalation disorders. So this can be the acute inhalation of something like, we recently, within the last 6 months anyway, we had a tanker truck spill over in northern Illinois that spilled a whole bunch of ammonia gas. And they actually, all of the patients, all of the people in the area, of course, came into Vista. And we intubated 7 patients in 30 minutes. It was pretty crazy. It was pretty cool. But it can be, from a house fire, smoke, and that would be an acute situation. Prolonged exposure could be due to something like oxygen toxicity. Again, if we intubate somebody, and generally when we do, we set the oxygen at like 100%, but it really shouldn't be 100%. It should be something more like 40%. And if people aren't paying attention and they don't turn that down, you can end up with oxygen toxicity. Or you have patients on home O2 and they're not breathing really well, so they crank up the tank at home thinking that's going to make things better. And then this I'm not even going to say it, the pneumoconiosis. I can never say that the right way. But anyway, this is a chronic exposure to like environmental hazards. This is your asbestos people. And you also have the situation where you have a hypersensitivity to inhaled allergens, and this causes massive mast cell degranulation. So you have all of this inflammation from a hypersensitivity. And then we have pulmonary edema, which is excess water in the lungs generally from heart disease, or it could be because of lung capillary injury and other processes that disrupt lymphatic drainage. The most common cause, though, of pulmonary edema, though, is left ventricle failure, and also ARDS, so acute respiratory distress syndrome, which is acute lung inflammation and alveolo-capillary injury. This is caused by either a lung injury or a systemic inflammatory process. And when I say a lung injury, it could be a lung infection, some type of insult to the lungs where you end up with this huge inflammatory process that goes on. And it could also be from an autoimmune issue as well. It affects both lungs. So if somebody's got something going on in only one lung, like a pneumonia, if you were to look at a chest x-ray and only one lung looks bad, it's not ARDS. ARDS affects both lungs. And it causes a persistent state of hypoxemia, even though you load them up with high doses. This is the patient you're blowing 100% O2 into, and you still end up with really low oxygen in the blood. And this, once you get to this point, this syndrome, you have a very high mortality because you end up going into like multiple organ dysfunction syndrome because you're having hypoxia at the organ level, but you're not perfusing it because of your hypoxemia. And then we have obstructive lung diseases. So this is the narrowing of the airways. So this is causing an obstruction, and generally it's not an obstruction of the fact that you can't inhale. It's an obstruction where you can't exhale. And these would be asthma, COPD, chronic bronchitis, and emphysema. With asthma, super common, you have a chronic airway inflammation and it's causing an expiratory wheezing. You can actually also hear inspiratory wheezing in some cases with asthma patients, but you most definitely hear it trying to squeak out. These patients will present complaining of shortness of breath. They may have retractions. They'll complain of chest pain. They may have a cough. But this all varies in time and intensity, and is treated with nebulizers with the albuterol or duoneb. Ipratropium bromide is the other medication that's combined with albuterol, and that's why it's called a duoneb. It's those two medications. You'll see also bronchial hyperresponsiveness, and again, this is reversible with those medications. It can be lethal if it's not. It's caused by the interactions of genetic and environmental factors. That's important to know. There is a genetic familial component to asthma, but you also have environmental factors that have to be there in order for this to occur. Status asthmaticus, this is our lethal situation where you have prolonged bronchial spasms causing a severe hypoxemia. These are your patients that don't have their inhaler with them. They're out and about somewhere. They have some type of reaction that causes a really bad asthma attack, and they don't have access to their inhaler, and they end up in a state of status asthmaticus, and they die. And it's amazing, in a bad way, how often this happens because people don't have their inhaler on them. So if you have asthma, make sure you always have your inhaler. Just like people that have significant allergies should always have their EpiPen with them. COPD, this is chronic and it's progressive. It gets worse and worse. It's a persistent limitation to airflow. It's caused by smoking, occupational hazards, air pollution, lots of times indoor air pollution. That'd be your secondhand smoke issue. And there's a genetic component to it as well. Chronic bronchitis, when you have this issue, you have a hypersecretion of very thick mucus from hypertrophied glands. This produces a chronic productive cough that lasts more than 3 months, and that's why it's chronic bronchitis versus acute bronchitis. The airway gets inflamed. I have 4 inhalant irritants, but it's from inherent inhalants. What did I write? It's inflammation from inhaled irritants. Anyhow, it makes a person more susceptible to infections. Their airway is very compromised, very easily can develop a pneumonia. And the secretions cause obstruction, and of course, like I stated, especially on expiration, and that's why it's the obstructive type of bronchitis. And then we have emphysema. So this is an abnormally large airway where you have stretched out alveolar walls that don't contract very well. They're not that compliant. They're just kind of floppy and stretched out. So you don't get really good gas exchange. You have that loss of elasticity and recoil when when they breathe out, and this causes air to actually get trapped in the lungs. Primary emphysema, which is the most common, is linked to an alpha-1 antitrypsin deficiency, and that's important to know. Infections of the respiratory tract. So they are actually the most common cause of short-term disability in the U.S. That was something new to me. I didn't know that. It's most often caused by upper airway infections. So you have your common cold, you have a sore throat, you have pharyngitis, laryngitis that resolve on their own and aren't usually a big deal. But then we get lower airway infections. And these infections are more common in the very young and in the very old. And in the very young, if you have these babies that have very chronic, often respiratory infections, these are the kids that are at really high risk of having sudden infant death syndrome, that's SIDS. So you really got to watch out for this, let the parents know. They really need to be vigilant in watching them, and absolutely lay them on their backs. Back to bed, right? That whole campaign. And these are the two common causes. Laying babies on their belly and chronic infections are our causes for SIDS. So with our infections here, our most common ones are acute bronchitis, pneumonia, tuberculosis, and abscesses. Yuck. Our acute bronchitis is an acute infection, as would be obvious. It's commonly caused by viruses and are self-limiting. So you work it through, like our COVID-19. It just does its, works through its course, lets our immune system have at it, and resolves all on its own. With these patients, they may have a fever, chest pain, a cough, chills, malaise, which is, significant fatigue. The non-productive cough is what they'll have unless they end up with a bacterial bronchitis, and then they'll have lung cheese. Pneumonia is an infection caused by anything, really, that's infectious. Bacteria, fungus, viruses, protozoa, and parasites. We have risk factors of advanced age, compromised immunity, lung disease, alcoholism, altered mental status, impaired swallowing, that aspiration pneumonia we talked about, smoking, endotracheal tube intubation is what that ETT stands for, so people on a vent, malnutrition, and immobilization. So pneumonias can be community-acquired pneumonia, that's what the CAP is, hospital-acquired pneumonia, or ventilator-acquired pneumonia. But, as we stated, they're often caused by aspiration, and actually intubated patients often aspirate because they have their airway wide open with a tube in it, and it's very easy for any type of reflux from the GI tract to easily get in there, and that's why they're at high risk for ventilator-associated pneumonia. Tuberculosis, or TB, this is caused by Mycobacterium tuberculosis. It causes localized, non-specific inflammation. It forms these little granulomas in areas of the lung that end up becoming necrotic, and through the inflammatory immune response of cleaning out that necrotic tissue, they end up forming scars. After the infection resolves, they get antibiotics for it. After the infection resolves, you still have this remaining dormant in the body, and it can reappear when there is some type of immunocompromised situation. A lot like the herpes, the chickenpox virus, which comes back as shingles. Tuberculosis is also latent like that, and it can come back. It is super highly contagious, and it's transmitted from person to person by airborne droplets. And this is why you need your N95 masks that are in very short supply right now when you go into a room with a patient that has TB. It's usually contained by the immune system when you get an infection. So you'll have people with a latent TB. They have no clinical signs. They never had a cough, nothing like that, but they will respond positively to a TB test. And then we have abscesses. Ugh. So these are, it's a circumscribed area, which means it's a specific area. It's an abscess. It's full of pus. It destroys the tissue in that area, forming this cavitation. It's often caused by aspiration related to alcohol abuse. You have your alcoholics passing out, aspirating, your seizure patients that aspirate when they're having a seizure, people with swallowing disorders, and people from general anesthesia having aspiration issues coming out of the anesthesia. It produces a super foul smelling sputum, as you would imagine, because it's full of pus and also may be full of blood, which again is our word hemoptysis. Moving on to pulmonary vascular disease. This is the major disruption in blood flow throughout the lungs. So this is our circulatory problem. It could be due to a pulmonary embolism, pulmonary hypertension, or cor pulmonale. Our pulmonary embolisms are caused by an embolus, usually from a DVT, and we talked about this when we talked about deep vein thrombosis. You have part of it that breaks off and ends up in our pulmonary system, causing the pulmonary embolism. The things that make people, our risk factors that make people highly prone to getting pulmonary embolisms is that Virchow's triad that we talked about before. So venous stasis, you've got your big varicose veins. They have a coagulation type of disorder of some sort, or they have inflammation in the lining, the endothelial lining, and these are kind of the perfect storm to end up with a pulmonary embolism. These patients will present with shortness of breath and chest pain. Oftentimes they'll have tachycardia and fatigue, so they'll come in and they're complaining of their shortness of breath and chest pain. They get worked up for cardiac issues. They get an EKG, check their troponins. Everything seems perfectly fine, but they're a little tachycardic, so something's going on. So you'll do a D-dimer. If the patient ends up with a positive D-dimer, which is indicative of some type of clotting process going on, then we do a CT and find that pulmonary embolism, and we end up putting them on an infusion of an anticoagulant. Our pulmonary hypertension is defined as a mean arterial pressure greater than or equal to 25 at rest. Most of these are caused by endothelial dysfunction or an overproduction of vasoconstrictors and a decrease of vasodilators. This can be the result of infections, pulmonary embolism, COPD, drugs, heritable defects. There's a whole bunch of reasons people could have pulmonary arterial hypertension. They're all listed in your book. I wasn't going to put them all in here. But what ends up happening is you end up with fibrosis from the remodeling due to these infections and other things that are going on, end up making the arterial system super non-compliant, non-elastic, and causing all of this resistance and pressure for your right ventricle to have to try and push against. And when that happens, you end up with cor pulmonale. So it's a secondary problem to the pulmonary hypertension, and this can cause right ventricular enlargement. You have that hypertrophy going on as it tries to compensate for this great pressure it's pushing against. And this ends up leading to dilation of the right ventricle, an eventual failure. And that is it. So quick run through of respiratory, and we'll move on to the next topic in a few days.